All right, hi everyone. So we're going to run straight on to what I think is a really great continuation of the conversation before speaking about cannabis for women's health. And I think this is a topic really where, just like the panelists in the previous conversation were talking about, we do have some evidence, there's a lot we do know, and yet there are a lot of questions, and also a lot of kind of myth and uncertainty around the topic. So I'm looking forward to digging into it. Before we do, I'll just introduce the panel. So to my left, we have Susanne Caspar, the CEO of Linnea. Did I pronounce that right? Yeah, great. And Dr. Dani Gordon, the Vice Chair of the Medical Cannabis Clinicians Society, and also from Israel, Yotam, who is the co-founder and CEO of Gynica. So thank you all for joining us today. So I want to jump right into it and ask this question of what we know. What research has been carried out on cannabis and cannabinoid treatments in general, I suppose, for women's health. If there are any specific trials you want to speak to, great. And I suppose also I'll throw in like a little sub-question on there of what's missing, you know, what's the next step. So Susanne, if you want to start us off, I'm guessing you all have a lot to say on the topic.
Yes, we have. Do you hear me? Can you hear me? Yeah. We have seen a lot of clinical studies in the area of women's health. But maybe I would like to start with what is missing, and then you can maybe go deeper in the other topics. We have seen that not a lot are really standardized clinical trials, not placebo-controlled. And I think this is really missing. If we check these, they are mentioning it's done with cannabis, but they didn't say it's done with which dosage. And so this, I think it's missing, because if we are later on maybe discuss what is missing for doctors, I think they really would like to have this double randomized, placebo-controlled clinical study. And these, I think, you find only some of them.
Yeah, absolutely. I mean, this is an issue for all different indications and conditions, I think, this question of study design. Let's move on. Dr. Gordon, if you'd like to jump in.
Yes, so within women's health, we have, I think, even a bigger challenge in some of the areas where we prescribe medical cannabis and where consumers are using CBD wellness products, and that the research is lagging behind even further. So what we're seeing now in a variety of women's health conditions, such as endometriosis, chronic pelvic pain, PMDD, which is a severe form of PMS, which is actually qualified as a mood disorder, is we're seeing real-world evidence again, like we just heard from Dr. Sleig and the other panelists. So that means that there's databases of patients. There's a big database in Canada that they've done some work, and they've asked patients, women who are using medical cannabis, if it's helping with symptoms of their endometriosis, of their other women's health symptoms. So we're seeing this real-world evidence collection, which is very good. But of course, we don't know what dosages might work best for a certain condition. There was an animal study a while back that looked at endometriosis in an animal model, and that high THC may be detrimental, and maybe it might help promote the spreading of that tissue. That hasn't been replicated in humans, and actually for endometriosis, cannabinoids are really promising, including THC, because it helps with quality of life, it helps with pain control. So we don't have, yes, as you pointed out, the RCT evidence, but we also could do a lot more than it has currently been done with real-world evidence. So we could look at more specific data sets for specific conditions. So right now, doctors are in a very hard position with women's health conditions, especially in this country where specialists must make the first prescription for medical cannabis. So I run my clinic here in the UK. We're an integrated medicine clinic. We prescribe cannabis. And if you were going to prescribe for, let's say, PMS, you would need an OBGYN to start that prescription. And to find an OBGYN who is willing to prescribe for PMS when there's no evidence, it's very difficult. So I think that is one of the challenges with the evidence base that we're seeing currently. And then, of course, there's the safety issues around pregnancy and breastfeeding. And that's challenging, as anyone in the pharmaceutical world will know, to get data on any drug in pregnancy and breastfeeding, because no one wants to test drugs in pregnant women and breastfeeding women. It's high risk. And it's the do no harm principle. But again, we do have real world evidence of women who have used cannabis in their pregnancies, they've used cannabis in breastfeeding. So we're starting to get some of that information, but the problem is most of that data is from recreational use, smoked recreational use cannabis. So if someone is pregnant and they're smoking anything, they're combusting a plant material, they're creating that carbonization, that's going to be a risk to the pregnancy, just like smoking cigarettes. So how that relates to even vaporized cannabis, even if it was high THC cannabis, we don't know. And of course, the cannabis we prescribe for people is vastly different dosages. Usually it's low THC. How that adds up and what the risk profile of that type of usage, that medical usage is, especially for non-epilepsy doses, which are quite low, we don't know. And are they going to match up with those recreational studies that are saying, you know, there's an association potentially with lower birth weights and smaller head circumferences and women who consume high THC, high dose cannabis recreationally in their pregnancy? I think that it probably won't be the same risk profile, but we don't yet know. So right now, even if someone becomes pregnant, you know, I have a patient who is using medical cannabis for their anxiety, for their quality of life. They have a complex pain condition. They've already failed all the other drug treatments. Are you going to put them back on the opioids when they're pregnant? What do you do with these patients? So it's very difficult to know what to do until we have more evidence. But also, I think it's all about partnering with the patient, giving them all of the evidence, and then saying at the end of the day, what is the least harmful thing to do? And it might be to keep prescribing them medical cannabis at a low dose. But needs to be supported by your peers. So then we're back to the whole, you know, how do you get peer support as a physician if you're prescribing for medical cannabis to someone in pregnancy? I haven't done it yet. I haven't been brave enough to do it. But there are situations where that actually might be the least harmful thing to do for somebody.
Yeah, really interesting. And I think also I would probably add in that education is necessary here as well, because, you know, it's one thing for physicians to be demanding the evidence, as obviously they should be, but they also need to understand the endocannabinoid system and how that interacts with the female reproductive system in order to really interpret any evidence, however scant, right? I know this is of particular interest to you, Yotam, in the work you're doing at Gynica. Do you want to jump in here?
Yeah, so I'll touch your last question as well. We need to divide it between historical and anecdotal evidence regarding the use of cannabis for women's health, as well as the scientific evidence out there. So historically, there's a lot of evidence about the use of cannabis to treat different women's health conditions, all the way from ancient China, Mesopotamia, Syria, for a variety of gynecological and other women's health conditions. As well as, you know, data about or evidence about the fact that even Queen Victoria was prescribed with cannabis or hemp tinctures to treat her severe menstrual pain. In addition to that, in the past few years, more and more, we see evidence coming from in scientific measures, all of the way from the fact that the female reproductive system contains the highest concentration of anandamide, an endocannabinoid, after the brain. Adds up to the fact that Dr. Gordon mentioned endometriosis. We know that there's actually a synergy between endocannabinoid deficiency of women who suffer from endometriosis. Women who suffer from endometriosis are linked to endocannabinoid deficiency. That means that potentially, if we're able to stabilize it in a way, we might be able to support not only the pain relief, but actually potentially the root of the problem. And with this in mind, again, as mentioned, the safety and toxicity aspects are very crucial comparing to other uses of cannabis, especially when we speak about local use. So Gynica, for example, is developing clinically validated products for intravaginal use, suppositories, lubricating gels, and as an anecdote, we see such products already sold mostly in North America, in legal states in the US, as well as in Canada already, at least 2 brands selling suppositories, for example. But when we speak about intravaginal use of cannabinoids, so when we compare to smoking, vaping, or even taking a drop of oil, where the safety profiles are quite well known for hundreds and thousands of years, when we speak about intravaginal use, no one knows whether we are not actually hurting anyone or jeopardizing their health. We know, for example, that some cannabinoids can actually impair ovulation and has other effects on fertility. And now, again, we need to look at the real-world evidence saying that women get wonderful relief for a variety of gynecological conditions from such products, and the fact that we cannot neglect the fact that it might not be safe for them to use. And with this in mind, we believe that, as mentioned also in the previous panel as well, bringing pharmaceutical standards to the medical cannabis market and for product development are extremely crucial, especially when we speak about novel dosage forms and consumption methods.
Maybe I'll just say one thing about the evidence. I think one of the issues I see, especially with women's health, is the conversation is very much skewed towards the potential harms, the risks. So the first question I always get asked is, what about pregnant women? Well, not all women are pregnant. Not all women want to become pregnant. And it's skewed more towards the harms versus the quality of life aspects that women are looking for in a medication to treat women's health conditions. And just like many of my other patients, men and women, many women's health conditions overlap with other conditions. So my patients with endometriosis, they often suffer from anxiety or low mood. They might have another pain condition, because endometriosis patients often do have more than one pain condition. They often have pelvic pain that is not coming from the endometriosis on top of that. So cannabis is a quality of life medicine that can treat a variety of these conditions. It doesn't cure them, but that's really, in my mind, often overlooked in favor of this, very much fixation really on the harms. And even the research we have so far coming out of the real world evidence for pregnancy, breastfeeding, we have to be cautious, obviously, but these are associations we're seeing. They're not causative, so we don't really know how much cannabis might be bad, or if it really is the cannabis or it's another confounding. Of course, some of these studies, these real world evidence databases, they try to control for these other confounding factors, but it's impossible to control for them all. So I think we always have to keep in mind what the difference is between an association and a causal link, because they're very, very different things. It's the same thing as saying, oh, well, we cured this in mice, or this did this in mice, so it's going to do the same thing in humans. They're not they're not the same thing.
Yeah, I think this is a really important point, and it links in really with what I wanted to speak about next, which is, I think really THC is like the main culprit here, right? Safety is important regardless, especially in pregnancy and in lactation, but when it comes to the real hesitation to move forward with any of these research, it really does come down to the impairing or intoxicating effects of THC, which leads me to ask, what about all the other cannabinoids? What about CBD and all of the other, minor cannabinoids, as we've come to call them? I can see you're moving your mic already. What do we know, and how can this maybe help us move forward when it does come to using cannabis for women's health?
Mm-hmm. And maybe I can answer this question. We are producer of GMP extracts for cannabinoids, and mainly for CBD and CBG. And we realized that it's really important to have this standardization, because if you are standardizing on, let's say, CBD, then you have a product totally different if you have a full extract, if you are standardizing on CBG, because we do some clinical trials, some preclinical trials, and we have seen that the results are really different. So I think it's really important to have these standardized products. Because if people are taking, let's say, one CBD, and we tested some competitors, and we have seen there is sometimes no CBD inside. There is, if you think there should be no THC inside, there is a high level of THC. And therefore, I really think it's very, very important to have these really good quality, standardized, controlled, so that patients who rely on what they are getting, that is really in the product, what is written on the outer package.
So I'm just going to go back to the THC question, because everyone is afraid of THC still. It's still a thing. And I think in a society in general, we have a fear of altered states in general, and which is really segueing into the... Is my mic on? I think it's okay. Doesn't sound like it's on.
People are nodding in the audience. You're good.
Which is, it segues into the psychedelics conversation as well. But what people don't really understand is that medicinal cannabis doses, when I'm prescribing someone a product with THC, they don't need the intoxication effect to get the medicinal effect. So we're not trying to intoxicate people. In fact, most of the patients, all of my patients come to see me, they can get cannabis easily off the street. It's cheaper than coming to me to get a prescription, especially currently. But they don't want to be high. But THC is an antispasmodic, so patients with endometriosis, a lot of them have IBS symptoms, they have spasm in the gut, it's a pain reliever, it works synergistically with CBD. So I think we have to change the conversation around THC as well, that it's not going to make our patients stoned or lazy or unproductive. And if you're getting those side effects, you're doing it wrong. And a lot of my patients have already tried cannabis. They found it's worked for them. They're maybe doing black market cannabis to self-medicate some of their symptoms, and they haven't been able to get it right. That's why they're coming to see me. So that's really our job as doctors, to know how to get the ratios of CBD and THC correct for each patient, use the start low, go slow approach, all of these things. So there's lots of other minor cannabinoids that are useful. CBG, for example, we know from the glioblastoma research that it's potentially very useful in some forms of brain cancer, especially combined with conventional chemotherapy. But it also, in preliminary evidence, is looking to be promising now for anxiety, maybe even for a subset of chronic pain patients, although that is more preliminary. And then, there's other minor cannabinoids that are starting to come out of the woodwork as well. I won't go through them all, but there's CBN, for example, which is less psychotropic, less intoxicating than THC, but it's calming. So a lot of my patients, even years ago when I first started prescribing cannabis, which feels like a lifetime ago now, they were finding that they preferred their cannabis in the chamber and using it again. So they were using old cannabis. And I didn't know why at the time, but it's probably now because they were using a product that, because they had heated it up once and then they were reheating it, it had already been partially kind of used up. More of the THC had converted to CBN. So there's so much out there in how we can apply this to women's health, just like in other pain conditions. People forget, women's health conditions, they're usually pain conditions, they're mental health conditions. They're slightly different, but they fall under similar buckets, actually. And we know cannabis is helpful for all of these conditions.
Maybe as you said, you as a doctor, you would like to control, and people don't want to be high, so maybe you would like to start with the low doses. But I think it's really hard if people maybe are smoking, so then you really don't have the control of doses. So therefore, I really think it's necessary to have more standardized products so that doctors really can start with a low dosage and increase dosage if it's necessary. I think it's important for the patient and as well for the doctors.
And we have those already. So, my patients are not smoking their cannabis, thank goodness. But you're right, when patients come to me and they're already smoking black market cannabis, we transition them onto medicinal products. They're all standardized to CBD and THC ratios. We now know what strain they come from. We know the chemovar. So it's really changing that way from when I first started prescribing, when we only knew the CBD and THC ratio. This is many years ago. But absolutely, we don't get our patients to smoke, and even the way that our patients are vaporizing has changed. So the new devices coming out are actually measuring the dosages in the vaporizer more and more accurately. So we're there in terms of using standardized products. We have been for many years, but of course, smoking on the black market, you're not going to get that control.
If I may add, so everyone's speaking about THC and CBD. In the past year or two, suddenly we're speaking about CBG and CBN and maybe terpenes. But actually, cannabis contains hundreds and hundreds of ingredients, other cannabinoids, other terpenes, flavonoids, other polyphenols that are active ingredients. And so far, the discussion is very narrow in terms of the two main ingredients, at least for the public. I think that here in this audience, it might be more in the awareness of this audience. But for the general public, no one knows pretty much anything except for THC and CBD. And it's very sad at the moment. It's part of the lack of education as well. And what we see actually in the past more than 3 years of running preclinical studies for different gynecological conditions such as endometriosis, menstrual pain, painful intercourse, lately even menopausal symptoms, is that the best results are actually not coming from those two main ingredients. And moreover, even though we hear wonderful feedbacks, real-world evidence from existing products in the market, for example, that let's say have 10 milligram THC or 10 plus 10 CBD and THC, we see, for example, better results with other ingredients and in specific ratios. Sometimes even the two exact same ingredients in exactly opposite concentrations, one of them would be a positive effect, while the exact same opposite ratio would give actually an undesired effect. So as for that, when we cannot just say CBD and THC are good for X and Y, because it's very important to also say how much, in what form, in what ratio and concentration are they, and also to address it in the right consumption methods. Because if we use a certain formulation in a sublingual manner, or in a cream, or in a patch, or in a vaginal suppository, for example, the effects are completely different. And it also relates to the THC question as well, about when using it in other forms, does it give you a psychoactive effect or not? Actually, the real-world evidence are contradicting, actually. Some would say that it does cause a psychoactive or psychotropic effect, while others don't. These are some of the things that need to be tested and studied properly and in the right way in order to bring such products to the front and also to be accepted and legitimized by both the regulators, both the medical community, both the scientific community, and moreover the industry.
Yeah, absolutely. You know, it's encouraging. Obviously, we've got a way to go, but it is encouraging to hear about, these developments and where we're moving. So we've got a couple of minutes left here, and I think that kind of, to me, the elephant in the room here is the stigma around both cannabis and women's health. So I'd love if we can kind of end on a positive note, if you'd be able to share what progress you see in kind of combating these stigmas and I suppose what needs to happen moving forward so that next time we're all together talking about this topic, we're, moving down to the direction we all want to see this go.
Yeah, I think the stigma is really there. When I'm sometimes I post some information about cannabis and mainly on CBD and none on THC, and I have a friend, she is working in the electricity area, she always say, oh, you sound like a drug dealer. So this is really, really funny. Yes, I think it's changing. I think we are realizing that in the whole world legislation is changing, and I think mainly it's related to THC, the stigma, and for the moment most of the people don't divide between CBD, CBG and THC, but I really think it's a matter of time, and legislation is really changing in a lot of countries.
I've seen a huge change since I started prescribing cannabis, I guess 7-8 years ago. So I'm really positive. So what I've seen in my practice is women of all ages coming to see me and telling me about, yes, they've tried cannabis, they want to try cannabis for their women's health symptoms or related symptoms, of all ages. So I've had, the oldest patient in my practice right now is 89. And, they span the lifespan. They want to get better control of their menopausal symptoms. They're talking about cannabis. My mother-in-law talks about these topics because this is what I do with her friends at her tennis club, and they're all in their 60s and 70s. And so I think it is really changing, even in the older generation who were taught that cannabis is bad and, it's a drug, it's going to make you high and you're going to become addicted to it. So I've already seen a huge shift. And I think there's also been a huge movement among women who maybe use recreational cannabis, who are mothers. I'm a mother myself. I have a young little boy. And even since I've had my own children, I've had lots of women reaching out to me saying how they're trying to fight the stigma of parents using cannabis. And that's really the big one, isn't it? Is, are you a bad parent if you use cannabis? But it's changing. The whole conversation is moving forward leaps and bounds, and I think it will only get better.
This is encouraging.
I like this question a lot because I published an article specifically on these two questions about the synergy between cannabis and women's health and the similarities that we see just a few months ago. And actually, I must say that both subjects have been neglected for so long. Honestly, we need to put it out there. And both cannabis has been shoved under the radar for so many years. I think that we're all aware of it, and as for that, are here, as well as women's health conditions. When we speak about taboos or specific, not too pleasant, let's say, subjects such as menstruation, intimacy, sexual wellness, these are things that are like shoved under the rug, in a way. And cannabis was quite the same for so long. And I must say that in the past 2 or 3 years, we suddenly see a rise. If I look at the women's health side, we see a rise in the interest and in the understanding that there are so many unmet needs for women. Leave aside cannabis for a second. And as for that, the rise in femtech, what's called now the emerging femtech industry, and the fact that dozens and dozens of companies are just setting up shop and establishing different activities, addressing different women's health conditions and unmet needs that have been literally not addressed for many, many years. And I think that we're in a good era where both subjects are now coming to the front. And in terms of similarities, I think that we need to bring, we mentioned it a lot here, evidence and science behind both subjects in order to really bring it to legitimization and acceptance and at the forefront. And mentioned earlier, key opinion leaders, real recognized standards. These are things that in both topics were not sufficiently discussed and addressed, not by the industry, not by the medical and the scientific community, and not by the regulators.
Yeah, absolutely. So we know where we need to go. All right, the numbers on the screen here are now red. They're going to start flashing soon. So thank you very much all for joining me on the panel. And it's lunchtime now, so you can all grab some food at the tables that are set up at the back of the hall. And we're going to be back here in an hour.